それではお時間となりましたので、ただいまよりフィリップスレスピロニクス合同会社共催によるランチョンセミナーを開催いたします。このセミナーの座長を京都大学大学院医学研究科呼吸管理睡眠制御学の教授であらせられます陳和夫先生にお願いいたします。それでは陳先生、よろしくお願いいたします。
はい、皆さんこんにちは。今日はですね、今非常に重要になってきている、CPAP のコンプライアンス等について、非常に巧妙なですね、マーク S. アロイア先生から講演をいただきたいと思います。May I speak your CV in Japanese shortly? アロイア先生はですね、クリニカルサイコロジーが専門でですね、ミシシッピ大学を1990年に出られて、現在のポジションがそのアソシエイトプロフェッサー、ディビジョンオブサイコロジカルメディシン、ディレクタースリープリサーチデパートメントオブメディシン、ナショナルジュイッシュヘルスで、お仕事をしている傍らですね、実はフィリップスの研究顧問としてもですね、活躍されているということで、このような職はですね、あまりたくさんの人がなってなくて、日本では例えば皆さんご存知のデビッド・ホワイト先生がですね、こういうような職に就かれてて、いわゆる教育職とその企業での職を2つこなされているという、米国でも非常に稀というかですね、逸材というような方かと思います。でCPAP は本邦でも40万人以上に使用されてますし、米国は今750万で、毎年約150万人の人がCPAP に入っているということを今年の ATS でも発表されてましたので、このコンプライアンスというのはアドヒアランスの非常に大きな問題になっております。本日従いましてですね、先生からPersonalizing and Helping Changing Health Behavior in OSA という大変貴重な講演していただけると思います。Please, Dr. Arroyo, to make a presentation. Thank you.
ありがとうございます。I know very little Japanese, so I can say that, and I can say konnichiwa. So I would first just like to start by giving you a little context, a little structure around what I'll be speaking about today. And this slide is a slide that Philips developed, and it's a slide that originally when I saw the slide, I thought of it as marketing. It's just marketing. But there's more to it than that. So I have been a health psychologist and studying how people change their health behavior for 20 years. And for 10 of those years, I've also worked for Philips. And that transition was difficult for me. When I was recruited to Philips by David White, I thought that the passion that I had as a clinician might be different than the passion in industry, that our motivations might be different. And over the last 10 years, I've found that I was wrong. That in fact, we all of us in this room, including the people who work for industry, have the same passion. We all want the best for our patients. We all want to help people live healthier lives. And sharing that passion is what my work is all about, and it is what you will see in our booth, the Dream Family we call it. It's what that is all about. We have now worked to put that passion of how people create change in their lives, how they live healthier lives, into our products. And I want you to think about this because it's going to be the central part of my talk. We all have patients that we have good relationships with, and we know that when we have a good relationship with our patients, they do better. They trust us more, and they do better. They use their treatment better. And what we try to do is help you develop tools, have tools for you to use to build those relationships. So that's what I'm going to talk about today. Oh, hold on. So it's all about activating, connecting, and personalizing therapy for each patient. So let me give you the context of why behavior change is important in healthcare. The World Health Organization suggested that by 2010, chronic disease would account for 60% of deaths and 43% of the global health burden. That's 6 years ago. By 2020, this will be 73% of deaths and 60% of the global health burden from chronic disease. And this is important because the only way to treat chronic disease is to change behavior. A chronic condition requires a behavior change. Now, most every aspect of healthcare today requires changing one's behavior. Even asking a patient to take a pill requires a change. And behavior change can be difficult. It's often transient. It's often short-lived. And it sometimes is very emotional to change one's behavior. One of the things that gets in the way of changing behavior is that we think it is intuitive. We think if our patients just knew what we knew, they would be better. Well, there is data to suggest that doctors do not take their medications any better than their patients. So it's not just a matter of knowledge. It's a matter of it being personal. And so our solutions must be personal. Now, I want to remind you about the behavior we're talking about. So here's an example of sleep apnea. This is a very typical patient. And we'll see now, we can measure that now, here we can measure there's no breathing. But watch this respiratory effort. And I know many of you see this all the time. But with the lights on, it's good to see. Watch the effort. It becomes more and more violent to try to breathe. And a message is sent to his brain that he's not breathing, and he will snort and gasp. And he will catch his breath. And then he goes right into another episode. This is very typical. And what is important to recognize is he has no idea that this is happening. His wife may know that this is happening, but he has no idea. Now, the good news is we have treatment. This is an old CPAP, but we have treatment for sleep apnea. That's the good news. The bad news is that adherence to treatment is pretty poor. In the United States, you're reimbursed for CPAP. And so the acceptance of CPAP is relatively high. 70 to 90% of people choose CPAP. But the average use is about half of the night, 3.5 to 5.5 hours a night. And there have been some other ways to look at adherence that have been put out there, like 4 hours a night, 5 out of 7 nights. And now we find about 50% of the people using 4 hours a night, 5 out of 7 nights. We've done a study, we got it up to 58%. Optimal use, 7 hours a night, still skipping 2 nights, is only 6%. And we've gotten it up to 21%. So there's a lot of room for growth. These are old studies, but the data haven't changed very much. Now, many people historically believed that if you ask patients why they're not using, they'll tell you what to fix. And patients say, it's too loud, it's too big, it's uncomfortable. Well, I want to remind you, this is the very first CPAP. You could put your coffee there. There's a lamp. And this is the very first mask in 1986. This isn't even the latest one, but in 2015, here's where we are. And you'll see today where we are in 2016. Many, many improvements have been made. But adherence has not changed a lot. So technology alone cannot change adherence. It's technology and personalization, technology and behavior. Technology and a good relationship with your doctor. That's what changes behavior. Now, we know that CPAP use is a behavior just like exercise, just like weight loss. because we've looked at it. I've studied behavior, or I've studied CPAP use for many years, and I always have a problem when people say good or bad adherence. There are many ways to use CPAP. We did a study that looked at the patterns of use. Here we found 7 patterns. I'm showing you 4. Here's a good user, 7 hours a night, very consistent. Here's a 4-hour user. Now these are the people that we tend to think take their mask off in the night, but in fact, this person is using 8 hours some nights and 0 other nights. So as a psychologist, that tells me a lot. I know they are capable of using all night. I just need to know why they're not using every night, okay? We also have found patterns where we have a decline in use after about 6 months, or an increase in use where they go from looking like this to looking like this, spontaneously. So we know that this is a behavior, and it's a behavior that can change. Now most of us ask the question, what is related to CPAP adherence? Is it men versus women? Is it old versus young? Is it people with high pressures? People with severe disease? Well, in fact, when you look across studies, these factors have very little predictive utility on adherence. They do not predict adherence very well across multiple studies. You may find 1 study or 2 studies that show a positive relationship between severity of disease and adherence, but overall, very little relationship. What we have done is looked at it from a psychological perspective, understanding why people make changes in their lives. And I'm going to talk just about a couple of theories. I'll focus on importance, the importance of making a change in your life. I'll focus on confidence, one's confidence that a change can be made. And I'll focus on vulnerability, feeling how vulnerable, at risk you feel from your disease. So confidence is the biggest predictor of success in any behavior, in work, in relationships, and in health. Confidence is the biggest predictor of success. So we know that if we can make someone feel confident in their doctor or confident in their CPAP use, that they will do better. We know they will do better. So I want you to think of, this is called self-efficacy, but it refers to one's confidence to make a change when that change is difficult. Let me give you an example. It's not, do I think I can keep from smoking? It is, do I think I can keep from smoking when I'm out having a drink with my friends in a situation that is very primed for that behavior? Do I think I can keep from doing it? Or for CPAP, it is, do I think I can use CPAP when I'm stuffy? Do I think I can use CPAP when I travel? That's the biggest predictor. Well, we found that these measures, if you measure them 1 week into CPAP use, they predict 20% of the variance in 6-month use. Just by measuring it after 1 week, if you ask how confident someone is, you can predict how they will use in 6 months. 20% of the variance over and above disease severity and demographics. If you ask that question at 3 months, they predict 40% of the variance, nearly. And if you ask the question concurrently at 6 months, it predicts almost half of the variance. So confidence is our target. Confidence is what we want to change because we will change behavior. One of the techniques to change confidence is called motivational enhancement. It's a technique from psychology that I've studied quite a bit. And it focuses on meeting the patient where they are in this journey to improve their health. The idea is that when you struggle to make a change in your life, you are ambivalent. there are pros and cons to making that change. Usually when you're struggling and you feel pros and cons, you give up. You feel badly. What motivational enhancement does is it helps you to embrace ambivalence. We highlight it. We talk about it. We say it's normal to feel two ways about making a change. And by highlighting it, we can help people through it. And we do it in a very personal way. And I'm going to give you examples. This first example I will show you is incorporated into some of our products at Philips, and I'll show you that in a minute. But it's called a scaling technique. I hope it's loud enough. Let's see if we can.
So if I could ask you how much you want to start using CPAP, and if I could ask you kind of to rate your motivation to use it from 1 to 10, where 1 is that you don't want to use it at all, and 10 is that you very much want to use it.
Probably like a 7 or 8.
A 7 or an 8?
Yeah.
Okay, what makes you say 7 or 8 instead of, say, 9 or 10?
It's sort of intimidating because it's equipment, and I don't know my way around equipment. It sort of baffles me, and so I'm afraid of having it at home and having to use it, and if I have any problems, I won't know what to do.
Okay. So that's a little confusing for you at the moment. You don't know how it's going to be. Okay. On the other hand, why a 7 or 8 instead of, say, a 4 or a 5?
Well, I'm willing to use it and work hard at it. I mean, it looks pretty cumbersome and weird, a little different than what I'm used to doing. Right. I want to feel better, and so, that's really my motivation for using it. But, I think I can probably be successful because I usually stick with things. I had some knee surgery a couple years ago, and it was really hard afterward. The PT was difficult, but I stuck with it, and I'm doing really good now. So I think I'll just think about that.
Okay. So you see some parallels between the experience that you had with the knee surgery and the physical therapy and using CPAP?
Probably, for what I know at this point.
Right. And so you feel two ways about this. You're a little bit intimidated by the machine and everything that you need to do in order to manage that, but you want to see the benefits.
Right. Approach avoidance.
Good.
So I want to highlight a few things about this dialogue, because if there's one thing I would ask everyone to think about, it's this technique. So we ask on a scale of 1 to 10 how motivated you are, and you get a number. And you ask, why isn't that motivation higher? And that's a very easy question for patients to answer, because we know what will get in our way. But the problem in medicine is we tend to focus on that answer, and we can never solve all the problems. So then we ask, why isn't your motivation lower? And that's the hard question. And that's where you get a lot of good information. So what you're really asking is, why are you motivated to use CPAP? And those answers are very personal. And she does a very good job. This is a training video for our clinical trial. But she does a very good job. She says, I think I can do it. I tend to stick with things. She also says, I had knee surgery, and it was hard, and I got through it. And so she's giving him many, many good bits of information to use when she struggles later. He can go back and say, I know you're struggling, but you remember your knee surgery and how you got through that? And that alone can help her get through it. So it's a very powerful tool. We don't worry about the barriers, the things that get in the way. We worry about the facilitators, the things that help us. I have one more video to show you of a technique called reverting to goals.
So it sounds like it's pretty important that I deal with this.
Well, one of the goals you and I talked about earlier was you want to feel like you're enjoying life again, which is something you found kind of hard to do when you feel so tired.
Yeah, it would be nice to be able to attend my kids' sports events or just enjoy that stuff that's going on at home with them.
Right, the stuff that you had been doing before.
Yeah.
Right. Well, the good news about this is that treating your apnea may be able to help.
So the beautiful thing about this dialogue is this shows you the relationship. Oftentimes, we have a relationship of doctor as the expert and patient as the receiver. And that's very good sometimes, and it works well sometimes. But sometimes, patients want to put you up here so that they don't relate to you. So she says, it sounds like you think I should use CPAP all the time. And he says, well, one of the goals you had was to do this and this. And she says, yes. And so he says, the good news is CPAP can help you. So he says, he puts it back on her to say, no, this is your goal. It's not my goal. It's your goal. And this is part of what the psychology of behavior change is. So it's a very good example. Because if she says, you want me to do this, and he says, yes, I do, she could say, well, but you don't. In her mind, she could say, but you don't really know me. Okay? So this is building trust. So we did a clinical trial of many of these therapeutic techniques. And the clinical trial was an NIH-sponsored trial, 300 people, and they went into one of three groups, either standard care, motivational enhancement, which I just showed you, or simple education, which is what we usually do in medicine. These were only 2 sessions, and they started after 1 week of CPAP therapy because we wanted to use experience with CPAP in our therapy. And then we followed them for a year. And here's what we found. If this is red is standard care, blue is education, and yellow is motivation. If in the first week you use lower than 2 hours a night, nothing helped you. Okay? But if you were ambivalent and you use between 2 and 5 hours in that first week, motivation enhancement worked for a full year. And that is designed for people who are ambivalent. And now, if you were a good user and you used for 6 or more hours a night in the first week, education works the best. And these are the people who keep coming back to see us and say, doctor, you saved my life. But these are the majority of your people. Okay? So we see these people back and we think, we did a very good job because we educated well. But these people stop seeing us because they need more of a relationship. They need something different. Okay? They need more to get them through. And I'll tell you what to do with these people in a minute. So don't be depressed. So this is a little bit about what we do with those people. There's this other factor called risk perception. How at risk am I for having a problem? So let's talk about smoking. I know smoking is a common thing in Japan. It was a more common thing in the United States years back. People who smoke know the health risks of smoking. In the United States, obesity is a very big problem. People know the health risks of obesity. It's not that they lack knowledge. They know about it, but do they feel at risk? Okay? So oftentimes we see people stop smoking when they have a heart attack or when they need a bypass surgery. My father had a quadruple bypass and he stopped smoking that day. So it's about the risk that you're at. So one of the studies we did was we decided, instead of showing people a video of someone else having sleep apnea, which we have done for years, and it created an emotional response, but it did not change behavior. We show them a video of themselves having sleep apnea. And many of the patients don't even believe they snore. And we show them. Now, we show them more than this. We show them 3 tracings. We show them heart rate. I'm sorry. We show them heart rate. We show them oxygen saturation. And we give them only 30 minutes of education before they get CPAP. This was a pilot study we did with 20 individuals. And in the red line, you see a personalized video. This is the patient seeing himself. And the blue line is the same education, but the patient seeing someone else. The only difference is you see yourself. And only one session before CPAP, 30 minutes, and we improved adherence by over 2 hours at 3 months. Now, I usually, as a scientist, I look at this and I say the sample size is way too small, but look at the standard deviations. To put it in another way, here, half of the people fall below 4.5 hours a night. Here, 0 fall below 4.5 hours a night. And one of the gentlemen, he cried when he saw himself. The news station interviewed him 3 years later when we got our large grant. We have about $4 million now to study this. The news organization showed him his video again, and he cried again. And what he said was, "I was drowning in my sleep." And the reason I say that is because no professional would ever tell him he was drowning in his sleep. It is wrong. You're not drowning in your sleep. But this is what he needed to feel emotionally to change his behavior. So it's about giving the right information, making it personal, and having the right relationships. So I was asked at Philips to put down behavior change on one slide, which is silly because I've done this for 20 years, but I did it. So I think behavior change involves 5 key factors. Personalization. It has to be meaningful, specific, and individualized. I need to feel like I'm at risk, and it's about me for me to change. It has to increase a sense of urgency that now's the right time, and give me a sense of confidence that I can do it, that I can be successful. So if you give a patient CPAP and say, use it all night, every night, and they go home and they use it 2 hours, they may feel like a failure, and they may not come back to see you. It should include social support, other people like me to help me. And it should honor autonomy. It's not the doctor that changes the patient's behavior. It's the patient that changes his or her behavior. So those 5 things. So we have built Dream Mapper, and we just launched it in Japan. I'm very proud of it. It's based a lot on my research. And it does several things to help build a relationship with the doctor. It's not to replace the doctor. It's to help people take a little bit of the doctor home with them and build that relationship. You can get feedback on your average use nightly. Goals are set based on how much you use. So if you only use 4 hours a night, your goal may be 4.5, not 8. And then when you reach that goal, you get rewarded, and your next goal may be 5. In psychology, we call that shaping. So it shapes you toward better use. You also get feedback on your apnea-hypopnea index residual, your mask fit. The goals, I said, are set. They're very personal to help build confidence. It does the 1 to 10 scaling that I showed you a video for later, and it records your answers. And when you start to slip in your CPAP use, you get back your own words about why you wanted to use CPAP. So it's very personal. It does some coaching and shows you a video of someone having sleep apnea, and has you hold your breath for 10 seconds while you're awake so that you understand what you're going through. And it can also do many, I don't have slides, but many problem solving. If your mask isn't fitting right, it can help you with some of that. And it's very personal to your device and your mask. And what we found, this was the first 15,000 people that we analyzed, half with no, it used to be called sleep mapper, half with no sleep mapper, and half with sleep mapper. We found a 22% improvement in adherence. We have adherence up to 78%. Now this is defined as 4 hours a night, 70% of the nights. Remember, I showed you that that's typically 50%, and standard care is 50%. Here it's 78. This was a very conservative analysis, so if you had a missing day, we put in a 0. We assumed no use. If we just looked at the people who were constantly downloading their cards, we still improved adherence by 10%. What's even more impressive is that we achieved high adherence rates quicker. In the United States, you can only achieve this criteria in the first 30 days. That's the soonest you can achieve it. We had higher adherence at 30 days with DreamMapper than without DreamMapper at 90 days. And what's most impressive is that if you looked at the people who used less than 2 hours a night, in the first 2 weeks, 1/3 of them went on to be adherent by 90 days, versus only 11% if they did not have this mobile application. It's also a website. But I want to make a very important point here. Remember, this is about a relationship. So there are two sides to every relationship. The patient should monitor his progress with something like DreamMapper. When we see patients with diabetes, we give them a blood glucose monitor and information about diabetes. So this is a monitor and information about apnea. Same thing. But the doctor also has a role. And Encore Anywhere is that part of that role. Encore Anywhere allows you to see their data. Now, in reality, you don't have to watch their data every day. But all your patient needs to know is that you have the capability of seeing their data. And now you have a relationship. We call it a digital relationship. The other very important thing that we've added to DreamMapper in Japan that only really works with Encore Anywhere is you can put the patient's next appointment into Encore Anywhere and it will go to their phone. So they have a reminder to come in and see you. And that should increase the amount of people who come back to see you because they want to keep their CPAP. In Australia, we have a model where you use CPAP for 2 months and then you pay $2,000 for the CPAP. We found that 55% of people buy their CPAP, but if they have DreamMapper, 90% buy their CPAP. So there's a commitment you're making to a product and to keeping that product. And there's a commitment you're making to the doctor and to keeping that relationship. So it really works best together, DreamMapper and Encore Anywhere. I want to conclude by saying brief behavioral therapies can improve adherence. They can change behavior. Newer ideals include digital solutions, video recording, feedback to help build trust in medicine by enhancing this relationship between the doctor and the patient. We should also consider the effort it takes to put an intervention into our existing programs, and that's the beauty of digital apps in health, is it doesn't take much effort. It doesn't take much effort. And so it doesn't require more on the clinic side, but it helps the patient build that relationship. For me, it's all about behavior change, helping change the way we care for our patients, using technology to activate, motivate, and empower both your patients and you. Thank you. I'm happy to take questions, and I'll also be at the booth to take questions with translation later.
Thank you, Dr. Arroyo. So we know the new information from your presentation. So now it is not so done that such a behavioral study and the patient face-to-face consultation by doctor. Therefore, there are many questions maybe in this session. どなたか、
Professor Tagaya of Kitasato University. Thank you very much for your excellent presentation. And I'd like to ask you to estimate or score my method, because I myself using CPAP, and I always tell my patients how I feeling better after CPAP treatment, and how my adherence data, and you should do this and you will get similar results. Do you think this method is also effective for motivated patients?
It's a very good question, and I think it's probably very effective for some people. But you know, Dr. Chin and I were talking about this, Professor Chin and I were talking about this over lunch. Some patients don't feel relief. Some patients don't even feel bad. You know, they don't even feel sleepy when they come in. So for those people, the change is hard to appreciate. So for those people, your message may not work very well. But we don't know. I think what we tend to do with those people is we talk about heart disease and we talk about the other problems they could have, but those are stories. What I like to do is ask them, why are you here? For you, why are you here? And then when they tell you why, and when we listen, that's what I talk about, whatever they want to talk about. So I think for some people that works very well. I do the same thing, and it's very easy to do, because I do the same thing with patients when I want to show them that it's not about me being here and you being here. We're together, right? We're together. You can do this, I can do this, and you can do this. So I think it's a very good bedside manner, and I suspect it works for some and has limited effect for others.
Thank you very much.
先ほど、ロイヤ先生はですね、いわゆるビヘビアルセラピーとしてもいろいろあると、フェイストゥフェイスのディスカッションもあるし、あるいはですね、ビデオでも一般のを見せるよりも、患者さん自身のビデオを撮って見せる方が非常に効果があると。であるいは最近の、これはフィリップスですけど、フィリップスのドリームなんというようなシステムで自分のいわゆるところに毎日のデータが出てくるわけですね。そのデータを見ながら時間を延ばしたりするとかいうようなことで、先ほど一つ示されてたファースト90デイですか、あれはですね、今米国ではメディケアという医療システムの中ではですね、最初の90日間の間のどこか連続30日で 70% 以上、すなわち20日以上4時間使ってたら初めて保険が下りるんですね。でそういうシステムがすでに一番大きい米国の保険会社でそのシステムが行われているので、ファースト90 days ですね、最初の90日間でそれをいかに達成するかということで、それをもし達成されたらその月から13ヶ月間保険が出るんですね。で13ヶ月間出た後、今度は5年間、残り3年9ヶ月はもう保険出ないんです。でまたそこから13ヶ月だけ保険出るというようなシステムなので、こういう米国の事情でこれが発展しているということには、最初の90日というのはそういうところもあるんですけど、しかし患者さんに自分のその電話のあれで見て、毎日ちょっとずつ増えることを喜びでなって増えれば、企業も最終的な患者さんのためなんですけども、そういう社会的背景もあってこういうふうに発展してきているということですけども、その他質問いかがでしょうか。So may I,
please.
So you show the brief behavioral therapy, face-to-face consultation. So how long? It's 30 minutes.
The first study was 2 sessions, 30 to 45 minutes. The second study with the video was one session, 30 minutes.
ほぼさん。So it is the cost of the communications paid by the insurance? No.
No, not,
No,
well,
no.
in some insurance it is, in some it's not. And this is why we developed the mobile app, because if the mobile app could do it, we wouldn't have to have insurance pay for it. I should add that we just analyzed the data. I showed you 15,000. We analyzed the data now with 172,000 people, and we see the same results. But yes, it's sometimes, depending on your insurance, it is reimbursed. Other times it's not face-to-face.
So in Japan, health insurance system is not paid by the adherence. So the probably in doctor in here, so sees a patient, 10 or 12 patient in 1 year. So it is very hard to communicate with the patient.
Right.
30 minutes
Right.
in one session.
Well, and that is, I think this is why Encore Anywhere and the mobile app helps in Japan, because all you want is them to use as much as possible and come back. And if they are committed to their therapy and they have a good relationship, then they come back.
Yes.
So.
However, so in Japanese patient, so who are very adhere the therapy or not, usually they come to the hospital every month or every 2 months. So it is very difficult to program how to manage make the patient adherence or CPAP therapy.
Right, with only a short period of time.
However, it is also our hope to use a CPAP machine more longer, more suitable for the patient.
Right.
However, it is very difficult to make such a system in Japan. Maybe it's same as in country.
Same in the U.S. Because in the U.S., most patients don't even go back to see their sleep doctor after 3 months, ever.
Yes, I think so. So, アメリカではですね、一般医がまず、so I would like to talk about system in United States. 一般医がその睡眠時無呼吸の方と疑われた方はまず一般医が診察してですね、それで決められた検査するところに行きなさいというわけですね。でそれはポリソモノグラフィーであってもタイプ3であっても最近知った話では、モニターのうち3つあればいいと。例えば、大体 SpO2 測りはるんですけど、あとプレッシャーとあと何であってもいいと。でもその3つを専門家がチェックすると。 PSG であってもタイプ3であっても別にもうタイプ4であってもその3つのモニターさえあればですね、専門家がそのデータをチェックして、それでこの人がしかも米国ではもう15以上やったらデフィニティブに使っていいですし、5回以上で眠気があるとかいわゆる高血圧があるとか糖尿病があるということであれば CPAP 処方することができるんですね。で CPAP が処方されたら今度は先ほどのシステムにのっとって最初の90日間でそのどこか連続30日の間の20日間をチェックすると。でそれが4時間以上超えてたら、メディケアのメディケアというシステムではペイされるわけですね。でもし当然脱落する患者さんいらっしゃると皆さんご存知当然いらっしゃるわけですけど、システムとしていいのはですね、脱落した患者さんがもう一回トライアルできるんですね。もう一回トライアルするときにはポリソモノグラフィーやらないといけないんですよ。その時にはタイプ3ではダメだと。そこは絶対ポリソモノグラフィーしないと、そこで多分ですね、無呼吸以外の睡眠障害をある種引っ掛けようというシステムが、構築されてるんじゃないかと私自身は思ってるんですけども。So I now told the audience in United States, so usual doctor consult the patient. Right. And they order the PSG or OSCT. Yeah. And by that data, so the specific doctor to check the polysomnography or the data, and the prescribe the CPAP machine.
Right.
And next to 90 days, so consecutive 30 days, so 70%, so usually 20 days, more than 4-hour CPAP use. So patient cost of CPAP is paid by the
yes.
Medicare or health insurance.
A portion of that cost, yes.
After that, if the patient failed to the test, patient re-challenges the test.
Right.
However, at that time, the patient should be done polysomnography, right?
Right, correct.
そうらしいです。だからおよそ3年9ヶ月、5年のうちの13ヶ月はペイされてるわけですけども、残り約3年9ヶ月は、その会社は、フィリップスさんは怒られるかもしれません、全くペイされなくて、各会社はマスクとかですね、その付属品を売るだけなんですね。したがって6ヶ月ぐらい経ったらマスク変えた方がいいですよとかいうことを各会社がプロバイダーがやれるんです。でもう一つちょっと違うのは、こういうことは日本では全部医師がやらないといけないわけですけども、in Japan, so change the setting or prescribe the CPAP machine that should be done by the doctor. However, in your country, so health provider can check the adherence,
yes.
and change the PAP pressure or humidifier.
So most in the United States, most changes to pressure are done most by the prescribing doctor. But the doctor who prescribes does not have to be a sleep specialist. Okay, so so changes can be made, but we also have home care providers who can do some of that connecting.
So home provider make the information to the doctor, and the doctor changes the pressure.
Right.
だから非常にある種たくさん処方されてるけどチェックは入ってるということで、このシステムが日本にはすぐ導入されることはないんですけども、多分いいところはだから検査自身見る人がきっちりスペシャリティが So I say the data from polysomnography or OSCT or other portable monitor checked by the specialist and prescribe the CPAP machine.
Yes, it's usually checked by the home care provider and then given back to the specialist. Yes. The PSG is always read by the specialist. But the data from the machine is checked usually by the home care provider.
その辺のシステムが少し違うということらしいです。いかがでしょうか。せっかくの機会ですので。日本語でもフィリップスの方が訳してくれますし、私の拙い英語で伝えてもいいんですけど、したがっておそらくですね、本法でも保険の改定とかが行われていく過程の中で、これから厳しい情勢になってきたとき、やはり使っている人に国民の財産が使われているというかですね、そういうようなシステムに徐々に移行、要するに CPAP 使っている人が多いということもあるわけ、しかし日本で40万人ですけど、彼らの国では750万人ですから、日本も同じ程度にいるとすればですね、50万、100万ってすぐいくと思うんですけども、システム的にいいとこを取り入れるということは大事なことで、もう一つああいうふうにやはり本法でも最初の過程の間で30分ぐらいフェイストゥフェイスですればですね、少し確かにコンプライアンス上がるような気はするわけですけど、なかなか私どもそういう難しい環境にあるかと思います。So I told the audience, so we would like to do the same method to face-to-face behavioral control for the patient, for individual patient. However, it is very difficult under the Japanese health insurance system. However, today we get the many information from you. It's best, I think it's very useful for the audience.
Thank you.
Therefore, I appreciated your presentation in this session. Now the time is closed. もし質問がなければ終わりにしたいかと。いかがでしょうか。なければもう一度拍手をしてこのセッションを終わり。Thank you very much.
Thank you.
ありがとうございました。以上をもちましてランチョンセミナーを終了いたします。
イノベーション&ユー、フィリップス